So we'll talk a little bit about another immune reaction, and that's inflammation. And really, it's another protection that the body has. Most of this information we have talked about when we looked at pain, because inflammation allows for your circulation to get blood cells to an area of injury. Plus, it also gives you an appreciation for a wound so that it causes pain, so that you respect it a little bit. So anyhow, most of this information is a repeat. Some of it is new. So I just wanted to put it together as inflammation while we're looking at the immune system. So we talked about Nsaids when we looked at pain, and Nsaids stands for non-steroidal anti-inflammatory agents. And we know that both pain and inflammation work on this arachidonic acid pathway. So your Nsaids work either on your leukotrienes or your prostaglandin pathway. So you've got two pathways that leads to inflammation. So while you are having inflammation, it's leading to pain. So the NSAIDs that will help reduce inflammation are going to actually have some analgesic effect as well. So like I said, this is a bit of a repeat when we looked at NSAIDs before. So our leukotrienic pathway is what leads to vasoconstriction. And so if we can block that, we can block, it leads to vasodilation because it makes our vessels leaky to cause inflammation. So if we can block it, we can reduce the amount of inflammation. So the next slide here is a repeat as well from when we looked at analgesics. And so we know that the NSAIDs, the mechanism of action is that it inhibits the leukotriene pathway or the prostaglandin pathway or both. And by blocking the chemical activity of your enzyme COX or your cyclooxidase, it will reduce that inflammation. So all of the NSAIDs have a few properties that they share, and that includes your antipyretic properties, analgesic properties, and anti-inflammatory properties. So aspirin, of course, has that antiplatelet activity. And always remember when I ask you what aspirin 81 is for, it's for antiplatelet activity, not for analgesic, anti-inflammatory. And they all have some side effects that we've talked about in the past, and that being that heartburn, or it can lead to severe GI bleeding. It can cause an acute kidney injury. So when we're looking at the kidney function depends on prostaglandins. So the afferent arteriole going into the kidney is kept open to allow blood flow by prostaglandins. So when we block prostaglandins, we're causing a constriction of blood flow to the kidney. So we can cause kidney injury when we're using long-term use of NSAIDs. So keep that in mind. The use of NSAIDs can compromise someone that has existing kidney function problems. So we want to make sure that our patient is healthy enough to be using NSAIDs, and that kidney toxicity can occur in patients when they're dehydrated, or if they have a low blood pressure related to heart failure, or if they have liver dysfunction. And so we need to keep that in mind when we're using NSAIDs. Also, adverse reactions can include non-cardiogenic pulmonary edema, so swelling in those lungs, altered hemostasis, of course, like aspirin can cause those slippery platelets, that hepatotoxicity as well as being renal toxic. It can cause problems with the liver. There can be skin sensitivities. And then with high doses of medication like aspirin, it can lead to tinnitus, or that ringing in the ears, as well as hearing loss. So we talked a bit about NSAIDs. So those are non-steroidal anti-inflammatories. I thought I should talk a little bit about steroids and how they work in inflammation as well. So from this picture, you can see that your immune system is part of your inflammatory cells. Now in term 6, we'll be covering the immune system again, especially when we're looking at some of those chronic immune system problems. But we have our cells that are part of the immune system that also cause inflammation. So some of the medications that are naturally anti-inflammatory are our steroids. And so I wanted to talk a little bit about prednisone, which is your most common use oral glucocorticoid, and it's used as an anti-inflammatory. It is used as an immunosuppressant as well, and in term 6, that's when we'll look at its immunosuppressant properties. Prednisone is also used to treat exacerbations of chronic respiratory illnesses, and we've talked about that in the past. And we know that it is also used as management for an adrenal insufficiency. So when we're looking at Addison's disease, and we've talked about that a little bit when we were looking at our fluid and our electrolytes. But mainly I wanted to talk about prednisone as its property for being an anti-inflammatory. So one of the bigger guns for anti-inflammatory is our methylprednisolone or Solumedrol, and it's the most widely used injectable glucocorticoid, and it is again used as its anti-inflammatory or immunosuppressant. And we'll see this often for our COPD patients that are coming in with inflammation in their lungs as a quick-acting glucocorticoid to help reduce that inflammation. It's not recommended for use in pregnancy. And one more bit of information I wanted to talk about is the look-alike, sound-alike drugs. So there is another drug that's Solu-Cortef, and the last drug on the last slide, it looks very similar, Solumedrol. These drugs are not interchangeable, so both are glucocorticoids, and both of them are given intravenously, but they are different. So 4 milligrams of Solumedrol is equivalent to 20 milligrams of Solu-Cortef. So Solumedrol is about 5 times stronger than Solu-Cortef. So keep that in mind. And there has been many medication errors because they look so much alike. Now both of them come in a vial that looks a little bit different than what you're used to seeing. What you do is you push this cap down. The fluid is in the neck of the bottle, the powder's in the bottom of the vial. When you push the cap down, it forces this stopper out, which allows the fluid to mix with the powder. You shake it up, you knock the little cap off the top, and then there is a stopper that you can empty the vial into a syringe to give it IV. So both of them, like I said, do look alike, but they are not interchangeable. So some of the adverse effects when we're looking at steroid use, they're wonderful when they're used. They work when they are used right. They work great. They do what they're supposed to. They cause that reduction in inflammation, but they have a potent effect on all body systems. So looking at your cardiovascular system, it can lead to heart failure, it can lead to cardiac edema, hypertension. They can cause electrolyte imbalances, so hypokalemia, hypernatremia, impaired glucose tolerance, dysrhythmias, bradycardia, syncope. Central nervous system, it can cause convulsions, headache, vertigo, mood swings, nervousness. It can cause aggressive behaviors. It can cause psychotic symptoms, peripheral neuropathy. Looking at the GI system, we know that it can lead to peptic ulcers, pancreatitis, esophageal ulcerations, abdominal distension. Looking at the skin, it can cause fragile skin, petechiae, ecchymosis, which is bruising. It can cause redness of the face. It actually can cause fat to move around in your body so that you get a fat deposit on the back of your neck and a big round moon face. It can also cause poor wound healing. and it can cause hirsutism, which is abnormal facial growth of hair for females. The MSK, it can cause, endocrine I missed here, growth suppression. For children, we don't want to use large doses of steroids for long term because it actually slows the growth down. It causes carbohydrate intolerance, hyperglycemia. MSK, it can cause myopathy, muscle weakness, loss of muscle mass, osteoporosis. It also comes with several steroid interactions, so aspirin and other non-steroidal anti-inflammatories can have an additive effect to anything else that causes gastric ulcer development. So we've talked about using medications to coat the lining if we're using long-term use of aspirin or other Nsaids. Alter your glucose serums, so an electrolyte level, so you're going to want to watch that closely. Oral forms can be given with food or milk to minimize some of the GI upset. You're going to want to watch your diabetic patients closely so that we can keep their blood sugars in good control. Want to take a quick look at gout. Gout is another inflammation, and this condition that results from an inappropriate uric acid metabolism, either an underexcretion of uric acid or an overproduction of uric acid. And those urate crystals deposited in tissues and joints, resulting in pain. And generally, they sit in your big toe and cause an inflammation of a terribly sore big toe. And it also shows up as hyperuricemia. So the anti-gout drugs that I wanted to take a quick look at is your allopurinol, and that is used to prevent uric acid production. It can lead to Stevens-Johnson syndrome, so we need to monitor patients' skin closely, let them know they need to report any type of rash. The other one that you'll see in Alberta Health Services is colchicine, and it's the oldest drug that is available as an anti-gout medication, and it reduces the inflammatory response to the deposits of those urate crystals in a joint. So those are a couple of medications I wanted to look at for gout, and that wraps up our few slides on inflammation.